I'm coming to this from a perspective of violence. I'm not a abortion researcher, I'm a domestic violence researcher. And today I was asked to give an overview, probably from a primary care perspective, but I couldn't help myself because we're at Children by Choice, that I've thrown in some reproductive and pregnancy areas as well, and I think they'll link well with what Kath and Liz are going to talk about afterwards. So I'm going to just cover some basic things and then talk a little bit about identification and responding, and in the process use some research and tell some stories, because that's always good. And just to clarify, because I think there's a million words for this, and I'd love to write an article sometime about the different terms that are used, but just when I'm speaking today about domestic violence, I'm actually meaning partner abuse by a partner, not the wealth of things that can happen in family violence. And to my mind, the research term is intimate partner violence, so you'll hear me use those interchangeably, and I see it as a spectrum of violence against women, including sexual assault. I'd like to acknowledge at this point that there'll be people in the audience who are definitely touched by this issue, and I hope whatever I say is empathic to your experience. I am going to be talking about intimate partner violence against women. I also acknowledge that men can be victims and that people in same-sex relationships. But today I'll be talking about men who use violence against their partners who are female. Just thought I'd clarify that up front. And just to ensure about the definition, because a lot of my work in the early 90s was around looking at definitions, and this is the World Health Organization definition, which obviously includes the physical, but I've highlighted the psychological abuse, the intimidation and belittling, and also there's sexual violence, but also various controlling behaviours, isolating from family and friends, monitoring movements, and deprivation of basic necessities. And that's the type of domestic violence, partner violence I'm talking about. And we're going to hear more about the reproductive coercion, but certainly this is the definition that Elizabeth Miller uses from the US, where it's against a partner's reproductive health or decision making and a collection of behaviours intended to pressure or coerce a partner into becoming a parent or ending a pregnancy. Very relevant to this organisation. But around the emotional abuse, many survivors say, at the time I felt that it was not really abuse, but the longer I thought about it, the more that I felt it was abuse. Emotional abuse is more severe than physical abuse, and there is no outward marks or bruises. And this is my experience from seeing patients in middle class Clifton Hill in Melbourne. If we look at how common it is, the World Health Organization, as some of you will know, recently released that 1 in 3 women had physical or sexual violence, and that range is from 15 to 71%. Luckily in this country we're around the 15%. If you look at the Australian Bureau of Statistics that was released last year, 17% of women and 5.3% of men have had experienced violence by a partner ever. Obviously the 70% is in places in Africa and Pakistan and places like that. A sad indictment on our country is that the majority of Indigenous women have experienced abuse either as a child or an adult, and disabled women and culturally and linguistically diverse women have a higher prevalence. And I think sexual violence has been a bit siloed from physical violence, but if you look at theirs, 3/4 of it is by someone they know. So, you know, the idea of, you know, our daughters or whatever, telling them to be worried about strangers, it's just not really that. And we were just starting to talk about, Zoe was just raising the issue around whether it increases or decreases. In the worldwide studies, it can increase or decrease. But certainly in the personal safety survey here, 1/5 of women had it occurred for the first time, and it certainly does occur during pregnancy. I'd like to acknowledge what my son's call is one of the domestic violence grandmothers who's sitting in the front row, which is Gwyneth Roberts here. When I was doing my PhD, Gwyneth was a great mentor and was doing her PhD, and she's the person who did the emergency department study there on your far left, and really was at the forefront of research in domestic violence in Queensland. And as you can see, the prevalence in clinical settings, we've heard about community settings, is really around that 1 in 4 figure. The darker one is lifetime and the other's 12 months. And I was a touchy-feely GP in West End, And I wasn't seeing 1 in 4 when I started my PhD in 1994, and this is what got me interested in it. And I developed this scale, and I'll just give you a little minute to have a look at it while I talk about it. So what I found was that there was a group of women who experienced severe combined abuse, and that's locked in the bedroom, kept from medical care, had a knife or gun used against them, forced to have sex and not allowed to work. No one argues with me about that being abuse, thank God. The next item was around the emotional abuse, which I talked about before. The next was physical abuse, being pushed and shoved. And the last was harassment, which was very prevalent in separated divorced. So this is some figures from Brisbane, randomly chosen general practices, and it's worth looking at the yellow group, which was that severe combined abuse. And that's 4.4%, or 1 in 25. There's another group who have physical and emotional abuse combined. So together that's 10%. So if you're a full-time GP, see 50 women, that's 5 women a week sitting in your general practice. Now, the GPs don't see that, I didn't see it. But if you ask women in the waiting room, that's how many are experiencing it. So it's very high prevalence. And we know why it's important, because more than 50 women die at the hands of their partners. It does cost a lot of money, and in Victoria, it's the leading contributor to death, disability and illness for Victorian women. Not that any medical students are taught on this subject unless I happen to do it, nor are nurses, nor are psychology students, nor are social workers always, and nor are psychiatrists. So now we're going to identification. And if you look worldwide, it's interesting to look. The OR just means the odds of that happening. And obviously depression and suicide in particular is very high, as are injuries worldwide. But induced abortion is high, and the sexually transmitted infections, and then the pregnancy-related outcomes. So that's globally, including obviously death, where 38% of female murders are by their partner. And so in sort of practice, these are the sorts of things. The non-physical are more common, and the physical are less common, but certainly I'm going to concentrate a little bit now on the terminations and miscarriages and talk to you about them. And here I went and said, Angela Taft, she's my mate from La Trobe, I'm going to talk at Children by Choice, and she does a lot of this work, and I've got all the references in my slides. And so she's given me some slides to talk to you about. And this is from the longitudinal study of women's health, a national random sample of women, very large sample, and she's done some secondary analysis with her group at La Trobe. And it's the same idea of when we started to discuss about the interlinking between socio-demographic factors, depression, termination, and partner violence. And I'm not going to get into it, but all those arrows. But what she's done is a careful analysis of the young women's cohort, which were in 1996 and 2000. So it's a little old now, but it's interesting. So if you just asked people, had they depressive symptoms, a third of young women in that age group do. 11% had a termination, 16% had a birth. 14% had partner violence. They weren't very good measures in the longitudinal women's health study, but they were better than nothing. And 20% had violence perpetrated by others. So I'll just take you through this slide a bit. So if you look at the first thing, this is the group who are depressed. And if you look at the green ones, the people who haven't had a termination, they haven't had a birth, and they haven't had violence, it's all under 30%. If you then look at the ones who've had terminations or births, they start to get above the 30%. If you then look at the partner violence, whether it's by partners or others, it starts to get up around the 40%. If you then, and the odds parallel that. If you then adjust it for socioeconomic, the only thing that remains linked to depression in young women is violence. And I suppose I'm just emphasising that because certainly, as I said, many mental health practitioners never ask about this. And so Angela's conclusion was if a young woman is pregnant, either having a termination or a birth confers a small non-significant risk. So that's what Dana's telling us. But experience of violence from a partner, a large significant risk. So that's where we should be putting our energies. I'm just going to show you a whole series of slides now where the purple is the people who've got the violence and pale blue is when they don't have the violence. And there are a whole set of things. So the first one is they're more likely to have earlier intercourse at a younger age. They're more likely to have their first birth at a younger age. They're more likely to, so the purple is the violence group. They're more likely to have miscarriages. They're more likely to have abortions. They're more likely to have adverse pregnancy outcomes, and they're more likely to have sexually transmitted infections. It's just showing you the whole pattern, and this is on a national sample. So pregnancy population, which is your unplanned pregnancy population in particular, is definitely present in this population as a risk factor for adverse outcomes. And I just like to also acknowledge that there'll be other children of the, of this woman who's pregnant, and it's got very large effects on children living in families where this is occurring. Okay, so it's a bit of a challenging issue for professionals, sometimes because of their own experience of domestic violence. They trouble believing the prevalence. The gendered nature, so I obviously do a lot of work with male medical students and male GPs, and what it means to be male and female, and sometimes it's just painful to listen to and feel as if you can't help. And certainly survivors or victims have a lot of barriers to disclosure about shame. They fear judgmental attitudes. They think the abuse is normal. They hope it will change. They love their partner often, and sometimes their partner's present. Perception that the doctor's unable to help or only deals with physical problems, or sometimes is because the doctor's male. But in fact, we've done a study that showed if the communication skills are the same, rated by the woman, for men and women, it's the same amount of disclosure. So it's actually the communication skills. I used to go telling them that I can't sleep. What I'm hoping is that they are asking me what is wrong. I think I'm scared to tell them sometimes. I don't say it's hurting here, they don't ask how the hurt came. And I think that was because of the fear of being denied that it's happened. And we don't ask as professionals. Most women, it's very 10% probably professionals have ever asked. And, the usual suspects, I haven't got enough time, I don't know what to do. They fear offending the patient, they believe it's private. Some female GPs actually fear the perpetrator. And they get frustrated because they think it won't change anything. But they don't get as frustrated with other things, physical things that aren't changing. So I think it's particular to this area. And it's very simple what helps women to disclose. If you listen, if you show that you're sympathetic, that some perception somehow that you might be there to help and won't tell anyone, and you ask. It's pretty simple. And, it's pretty clear that we should ask typical presentations, and particularly in women who are separated or divorced or have some sort of family history. And majority of women would find it very acceptable to be asked. And these are the sorts of things I teach GPs about how to ask, how, start from the general and move down to feeling safe at home, are they afraid of their partner, and then directly. And, the GPs actually find this quite easy to do once you talk to them about it. And these are some sexual and reproductive health questions, but I think Kath and Liz are going to go into this a little bit more. But the idea of asking about, has your partner tried to get you pregnant or forced you to have an abortion, etc., purposely giving you a sexually transmitted infection. So now I'm up to the bit where we talk about how I talk to primary care practitioners about responding, and we're almost at the end. So this was a lovely study by Gene Feder and his group in Bristol, and he's a GP there, and he summarised all the qualitative studies, asking interviews of women what they wanted. It was pretty simple. Before disclosure, they wanted some poster or something, some idea, like a rainbow flag for same-sex stuff, some no to violence thing. Privacy and confidentiality addressed. When it was raised, they wanted non-judgmental, compassionate and caring, and not pressurised to fully disclose. When you did disclose, they wanted you to take, listen and address safety concerns and understand that it's a chronic problem, social problem, but it's still a chronic problem, and respect whatever they chose to do, which often was to stay with the partner. And I taught the GPs just a little safety assessment piece about how safe does she feel, is she afraid of going home today, stuff about weapons and violence escalating, and what sort of history of psychiatric or drug history. And then simple things about safety plans. Now we'd love everybody to be referred to specialised services so they could get a proper risk assessment and a proper safety plan. But many of these women haven't even named it as domestic violence, so it's very hard to get them to that. As this survivor says, as it was, I guess, in some sense, a bit of a relief finding out it wasn't me, that these situations weren't normal, that it's not how a relationship should be. The GP went through, and I hadn't even thought of that, any of that kind of stuff, how to be able to get in the car and leave, make sure my car wasn't getting blocked, having my bag and my keys in a reachable place that I didn't get trapped. Another survivor, I realised when they became teenagers that I had to stand up to David, but just before that, I looked at the children and thought, they're looking because they're going to grow up believing this is the way it should work, and it can't be this way. I think it just slowly evolved, that I just got stronger. So women have turning points or catalysts at different times, and I see a lot of women, I actually find crisis women easy because then I ring the crisis line, but most of the women that I'm seeing in primary care or others are seeing are not even naming it. So, it takes some work to work with them to recognise what's happening. The World Health Organisation guidelines, I had the privilege of being on this guideline group last year with a range of women from around the world. And they looked at all the systematic reviews, and they came up with these things that have got enough evidence. So the women-centred care, I've probably been talking about an example of that, and I'll talk a bit further. Training all health professionals, the idea of case finding when there's indicators, written information in private areas. We couldn't find any evidence for supporting mandatory reporting, although that does happen in the Northern Territory here. And that psychological treatments do work for women, and that mother-child interventions do work. And I'm just going to illustrate in the final section here about the women-centred care. And so they had this mnemonic called LIVES, which is the first line, the idea that in the world, wouldn't we love it if everybody could give a first-line response to someone who disclosed abuse. So it's very simple what the WHO are recommending. Listen, inquire about needs, validate, enhance safety, and ensure support. Minimum requirements for doing that are some sort of protocol, training, private setting, and a system for referral to the local resources. The Lancet's just published last week on the 21st, a Violence Against Women series, and I'd recommend you all go and have a look at it. It's on various things. One's on engaging men and boys in this activity. This one was on the health systems response, and it's great. It's a great series. There's 5 articles with a call to action. I'm going to finish with an example of a study that I did that was a randomised controlled trial, really putting into place what I just talked about, teaching GPs to do this. And the idea was that would increase women's comfort to discuss and name and perceive support. They would feel more empowered and ready to take action. And we looked at outcomes of safety planning and improvement, mental health and quality of life. We screened about 8,000 women from 50 practices, and we screened using being afraid of their partner, buried in lifestyle type issues of smoking and drinking and other things. And what we found is that that sort of intervention decreased depressive symptoms at 12 months and increased safety discussion with the general practitioner, but didn't change the quality of life. So I'll finish with a quote. What the GP did, she started to understand when I was coming in and I was sick and stressed, the feeling of being able to acknowledge that it actually was abuse. I think that because I'd been seeing the GP for so many years, it made it a lot easier for me to open up. Just talking, allowing me to release built-up emotions, she encouraged me to take time for myself. Life for me now is just becoming more enjoyable, actually having things to look forward to, not just trying to survive. I probably would have just kept plodding along with the way life was if I hadn't got the Weaves invite. I still find the Weaves GP is probably my anchor, my centre point for going for things. She regularly keeps track of me. She's been my main focal point. The rest are just people that I see to help assist with getting through the journey. I hope I've inspired you to be anchors and focal points as we assist women on their pathway to healing and safety. This is some resources that we've recently developed. Updated the white book, which once again, Gwen's Rob was involved in previously, and also we're getting a new health practitioner support line through 1-800-RESPECT next year, and there's the adult surviving child abuse trauma guidelines are fantastic as well. And I've got references there and ready for questions.
Thank you, Kelsey. We have got a few minutes left. We'll take a little bit of time. Has Kelsey's here. So we're having some wine and cheese outside within about 45 minutes. So there's an opportunity to sneak up to Kelsey and have a conversation. Annabelle's got a question?
Yes, just unless there's anyone else. Just a question in regard to the recommendations for GPs around exploring the issue, and whether the issue of children and how they are in the family is part of that.
Yeah, I think this is a really interesting issue because there's been some push for witnessing or experiencing or hearing domestic violence to be in the child abuse definition, particularly the mandatory reporting child abuse definition. And this is just such a complex area. I think that our child protection system is failing as it exists now. Like, essentially, if I ring up and it's emotional abuse and neglect, in Victoria, hardly anything gets taken. And particularly when the man and the woman are separated and it's actually the man who is likely to be perpetrating child abuse or neglect. And what happens is we have an organisation called Child First, which is for vulnerable before you get to child protection, and it's great. What they do is they work with the protective mother, but she's already protective, and so it's you know, and they don't go and see the dad. I can't say how frustrating this is. The system in the UK is interesting. So they don't have mandatory reporting in the UK. They have mandatory child safeguarding training for every GP. And I actually think this is an interesting thing. And Jean Feder has started to do intersecting mandatory domestic violence training with the safeguarding. And I think that that's something, but you know, we'd have to change our whole system. Let's do it. Yeah.
Let's do it.
All right. Thank you, Kelsey. Okay.